Good afternoon, everyone. This is Carlos De Leon. I'm with Joan King and Jeff Capobianco, and we welcome you to the National Council's Data Everywhere webinar. Before we begin, I'd like to go over just a few housekeeping notes. Today's webinar is being recorded, and all participants are currently in listen-only mode. Please go ahead and place your phones on mute to eliminate any background noises. And when you would like to speak, please unmute your line and follow the on-screen prompts. If you're using your computer speakers and microphone, please mute those as well if you're not speaking, because sometimes we do hear background noise. Also, throughout the webinar, if you do have a question, you may submit those questions through the webinar by typing it in your questions in the dialog box to the right of your screen and sending it to the organizer. We'll answer as many of your questions as time allows after our speakers have presented. If at any point during the webinar you experience technical difficulties, please call Citrix tech support at 888-259-8414. And now I'd like to hand it over to Joan, which she could do the introductions, and we'll be on our way.
Hi, good afternoon, everyone, and it's great to see many of you joining us today. And I'm actually in Montana today, so today I'm in Great Falls. So it's wonderful to be with you while in your state while we're doing this webinar. And I'm very excited to have Jeff Capobianco with us today. Jeff has been a key leader in our Center for Integrated Health Solutions, and his responsibility there has been around data. His background is in using data to improve clinical care and program evaluation. He is a wealth of resources and information. So in a minute I'm going to turn it over to him. I just wanted to say one thing because I'm going to have to duck off because I'm doing a site visit here in Great Falls. So I'm going to duck out after we get Jeff started. So I just want to remind you all that, and there was a slide at the end to remind you of this, in case we don't get to all your questions today, we will have an opportunity to have more conversation on our group call, which is next Wednesday, October 12th at 1 o'clock your time. And we'll be entertaining questions from this webinar then, along with other topics. And please feel free to send me topics or questions you want to make sure that we talk about on that group call. And with that, I will turn it over to my colleague, Jeff. And Jeff, thank you so much for being with us this afternoon, and really look forward to what you have to offer.
Great, thank you, Joan. Hello, everyone. And I just want to make Carlos, you can see my screen. Good to go?
Yep.
All right, great. So we've got a fast-paced webinar today. I've got a lot of ground to cover, so I'll be speaking quickly. Luckily, you'll have these slides, and you have access to us during and after the webinar. So if anything's not clear, we're always here to follow up. We're going to be talking about several terms: value-based purchasing, population health management, and risk adjustment, because these are terms that are in play right now in the healthcare marketplace to a big extent in several states in our country, and it'll be coming to Montana very soon. We're going to be speaking about those terms in the context of using data to inform care. So we're going to talk a little bit about the difference between data, information, and knowledge. We'll be talking about how to actually conduct population health management in your clinics, and even use some examples for that. And then at the end, we're briefly going to talk about some of the mechanisms and staff capacities that organizations need to have in place in order to actually pull this off, all of which you guys have or are in the process of developing, I'm sure. So why the big focus on data? You know, Joan titled this Data Everywhere, because many of us who are traveling around the country, that's just seems to be how it feels. For a long time, we've been hearing as healthcare providers about the triple aim and the need to do population health management to control costs and to make sure our services are customer friendly. this notion of using data is now not just a notion, it's actually a requirement in many states, including yours. And there's good and bad to it. If you're an organization that isn't very good at this, it can be painful. But once you get data into motion and start using it in ways that are useful to you and your workflows, we've really seen it be a turning point for organizations from being tired and confused about what they did and feeling stressed out to actually feeling more in control about your clinical processes and how you do your work. So measuring things really does improve processes. I often think of data as a bright light that shines on a process. When you shine that light, you can see things you hadn't seen before, and that's really what data and measurement bring to you. It's an art and a science, and we'll talk about that in this presentation. So if we take a deeper dive into the triple aim, what it really is getting at is how to provide effective and efficient health care. So effective health care is doing the right things. So identifying the right patient needs through screenings, giving them the right treatments that are person-centered and trauma-informed, using the right team members to deliver that care so people are working at the top of their licenses and billing effectively, doing things in the right time order so that we're not coming in too late after somebody shows up to the ER, we're preventing the ER visit, and then producing the right health outcomes, having treat-to-target metrics in place to know where you and your patient are going in their journey towards better health. That all has to be done with activated patients, so the patients have to be satisfied with those outcomes. We are working in a field that's a lot like education where the products we create are actually our customers. So those are one and the same. People come to us and want to feel better. What they have to change is who they are, and we help them do that. Not an easy thing to do. So it's not okay to just be effective. You actually have to do it efficiently and come in at the right cost. So these clinical administrative workflows really need to be understood well so that you can hit your time and cost specifications and get reimbursed in a way that you are at least breaking even, if not making a little bit of money. So this is a big challenge for us, and data really brings this to reality and allows us to actually be able to pull off efficient and effective care. The terms we're seeing used a lot today are these: value-based purchasing, not a new term, but definitely one that's being thrown around a lot in the Medicare space. And as we know, where Medicare goes, Medicaid goes. So we are going to be hearing a lot more about that. To actually do value-based purchasing, defined as the ability to purchase services from a provider that are going to produce specific quality outcomes, meaning you as a provider are going to get paid for producing specific measurable outcomes. You need to have population health management tools in place. That is a requirement. And part of population health management is risk stratification. Risk stratification is a term that oftentimes gets confused with very high-level statistical analysis and risk adjusting populations of people. And certainly that can be what we're talking about with risk stratification. But here, we're simply looking at risk stratification as the process of identifying where people's needs are. Are they at risk for going to the ER and need a preventative intervention? Or are they at risk for just needing some health education? Because if they don't get that, then they're not going to get the preventative care they need. Risk is really defined as where is the person in their understanding of the care they need? Where are they in the understanding of what they need to do themselves to be activated and actually get better? So risk really is finding the patient at the right time in their care processes, educating them about their health and what they need to do and what you're going to do so that you prevent them from exacerbating their health conditions or using services ineffectively, so going to the ER when they could have been treated in the community. So these terms are really build on each other. You're going to hear a lot more about them, and we're going to talk a lot more about them, but you're going to be hearing a lot more about these as time goes on in the next couple years. As I mentioned, value-based purchasing is not a new term. It's an old term, been around. This is a 1997 ARC white paper. Talks about the value-based purchasing and what it is and why it's so important. We have really moved from talking about integration to value-based purchasing and population health management and risk stratification or risk adjustment as the new terms you're going to be hearing a lot about. So we've kind of, in the process of transitioning away from integrated health into these new terms, integrated health being important, but the field is kind of expecting that we're already doing that. Things move quickly in our field for sure. So let's talk about just a few more terms before we get into some worked examples here and get into some of the steps you'd need to do to actually do this work on the ground. This term data, it's very important that we and our staff understand the difference between data, information, and knowledge. So data really is just one data point. It's one bit of information, it's one bit of data or numbers at the granular level, and it's very much unprocessed. So this is one A1C lab value or one PHQ-9 score or one blood pressure score for one patient. It's important, it tells us something, but it doesn't tell us a lot. It's kind of like one piece of the puzzle before you stick it in the puzzle with all the other pieces connected correctly. Data is very important, but you need lots of it to hear the story it's trying to tell you. Data, as I mentioned before, I like to use the metaphors as data has a voice, but it's very quiet unless you get lots of it together and start to hear it all singing together in chorus. Data also is a bright light, as I mentioned. It's another metaphor. And one data point is kind of like one candle. But if you put a whole bunch of blood pressures together on one patient, you get a bright light, which is really explains better their heart health over time, right? And then if you get a couple thousand blood pressures together on a couple hundred different patients, you get even more light. You get even more clarity in the data's voice about what's happening with a population of people's health related to their cardiovascular disease if we're talking about blood pressures. So when you bring data together, it becomes information. And this is a term we often hear thrown around, big data. Just this notion that you bring lots of data together, organize it into a data set that can actually be measured and stratified. You can risk stratify those data. You start to really hear what's going on. So you take multiple A1C scores and multiple blood pressures and multiple PHQ-9s, and you start to hear the story of an individual's health or a population of people's health. Once you get all those data together, you have knowledge. Now, the difference between information and knowledge is actionable. Information sits there and lets you play with it and hypothesize with it. Knowledge is what you do when you make a decision on those data. You make a decision about that information you have in front of you. And this is very much where we are in healthcare today, where payers are expecting you to have data that you can make decisions about, draw hypotheses, do quality improvement processes around, and make decisions. So as you can see, data turns into information, which turns into knowledge, which turns into action. And this is very much the continuous quality improvement process that you've all heard so much about in your careers in healthcare. Quality improvement is about turning data into action. So when we're talking about population health is this notion that we're going to take data, turn it into information, and make decisions about it. We're going to gain knowledge and make decisions. And the reason why population health management is so important in this value-based environment we're in is that we now have the ability with our electronic health records and health information exchanges, we now have the ability to look at groups of data for populations of people and design interventions that are going to address multiple people at once, not just individuals, which is very important that we treat each individual. But we now have the ability to look at data related to groups of people. So we can now look at all the diabetics we treat in our clinics and design sets of interventions that are going to address diabetes for groups of people. It allows us to stratify what the different populations of diabetics are in our health information registry and say, let's look at all the kids who have early onset diabetes or type 1 diabetes. Let's look at all the adults. Let's look at all the different ethnicities. We can start to slice and dice that data and look at all the people we serve through different angles with different lights shining on those data to learn different things about them. So it's a very, very powerful tool that our electronic health records and our health information exchanges have allowed us to start sharing these data and to start playing with it and really learn more. I know many of us don't like our electronic health records, or we're in the process of moving from a paper record into an electronic health record, but they're getting much, much better, and it's only going to get better over time. So these electronic health records are only going to be able to allow us to do better population health management in the future. So we have a bright future to look forward to. The other thing that population health management does for us, it allows us to really do this risk adjustment or risk stratification. So it allows us to design different interventions based on people's needs as they present to us. So for people who are homeless and have schizophrenia and don't believe they have it, these folks are really at risk for harm living in the streets, and they're at risk of developing different health conditions based on the fact that they have no insight into their schizophrenia. So we would stratify these people into a high-risk category, and we would assign certain services to them, like assertive community treatment or some intensive outpatient or case management or maybe even inpatient treatment to them, and they would be considered stratified into a risk that is high. And we would want to move them or step them down to a risk level that's lesser as they get healthier and as we provide more and more services to them. So this population health management really is systematically assessing and tracking groups' health conditions in their treatment response to the services that you're giving them, which is a very, very powerful thing that we're able to do now better than ever in healthcare. The principles of population health management are these, and by principles, I simply mean these are the things that you have to have in place if you're going to do population health management. These are kind of the bones of population health management that you hang everything on and it allows you to kind of fill out your ability to do population health management. You need to have a population healthcare focus, so your staff and your organization has to be thinking of populations of people, not just individuals. They have to be thinking about who's in our zip code that's not coming into care and how can we get them into our services. So all staff have to be thinking not just of the individual treatment plan, but care pathways and large interventions you're going to do for groups of people. So what does our diabetes care pathway look like? And how do we use it to manage our population of diabetics? It has to be data-driven, which we've talked a lot about. It has to be evidence-based. So evidence-based practice are practices that have been shown through research to be effective and create certain targeted outcomes. There are some things that don't have a lot of research around them, and those would be called best or promising practices. If there are no evidence-based practices for a condition you're going to treat, you're going to go to the best or the promising practice and look in the literature to find out what do we know works the best. And again, with the availability of data we have now, we're better able to do these evidence-based practices than ever because we can track the data, we can see the impact of our standardized service delivery that comes through evidence-based practice. And then finally, one of the principles with population health management is this care management aspect, where we are aggressively screening, intervening, and monitoring based on the interventions we provide, the treatment plan we provide, to see if people are getting better or not. And if they're not, we're managing their care. We're helping them transition to new medications, new ways of getting services, new services altogether if some services aren't working. So this notion that we don't just put treatment plans together and launch people out into the community with their treatment plan in hand, we actually go with them and monitor their treatment plan as they're doing it as best we can and really manage that care. There's been a lot of talk from case management to care management, and this is that whole notion that we're not just managing a case or one specific condition, we're managing the whole person, their whole health, and we're care managing with them as a patient. So these principles, kind of high-level conceptual, we can distill down into 4 basic components if you're going to do population health management tomorrow in your clinic, which after this presentation you will be able to do, some version thereof. First thing you got to do is basically just know what to ask your population. You know, what are we going to ask about our population? The second thing is to have that data registry, that place where individual data points come together in aggregate so you can start developing a hypothesis and making actions around them. That's that information and knowledge piece. Then you have to be good at quality improvement. And quality improvement is all about analyzing care pathways, analyzing workflows in your clinic to see what works, what doesn't work when we try to deliver the best care, the most efficient and effective care to the people we serve. And then finally, once you hit the sweet spot and people are getting better and you think your processes are going really well, how do you monitor those continuously to make sure that you can sustain those data specification targets? So if you really want to, you have a lot of people with high blood pressure and you want to get those people within normal limits for their blood pressure and you're actually able to pull it off, how do you keep it that way and not have those high blood pressures wander up again over time? How do you monitor those and sustain those targets you created for getting everybody's blood pressure within normal limits or a certain percentage of that population? So these are the steps you go through, and I'm going to go through them now and give you an example too. But before I do that, any questions? Have we seen any questions come through, Carlos?
I haven't seen any questions in the chat function yet.
Really encourage people to ask questions if you have any. You can raise your hand and we'll open your line, or if you're shy, you can just type them in the box. Carlos will remind me and say, hey, we got a question, and we'll take it. There are no silly questions. They're all good questions. So if there's things I'm saying that you disagree with, you're confused by, please speak up. So let's go through. Great.
We have one question, actually. The question is, what do you recommend for registries?
So registries are interesting. Technically, all electronic health records should have registries built into them. A registry is a place where data go to be aggregated. So it allows you to risk stratify data, cut data. The problem with a lot of electronic health records is the registries are designed or turned on where you have to pay more money for them. So there are off-the-shelf products you can purchase that are data registries attached to you. They are not inexpensive, but they are very powerful. There are a lot of them out there. I couldn't recommend one in particular. If you don't have the money to buy a data registry, which is a place where you dump your electronic health record data into so you could analyze it, and you don't like your current electronic health record because it doesn't do a good job with developing data reports and doing that data registry piece, then you can simply do data registry work in Excel. And most people do have Excel and Access databases, which are a bunch of Excel spreadsheets linked together or workbooks linked together. So at the very basic level, I suggest if you don't have anything to draw on for a registry, start with Excel. Just pick one set of data points you're going to monitor for a population of people. Be very simple about it. Use Excel. If you can use your EMR, leverage that. That's the ideal. If you've got the money, go out and get yourself an electronic registry that's off the shelf that will plug into your whatever electronic health record you have so you can start mining your data and doing this population health management work.
There's another question that came up, Jeff.
Great. So let's jump into these. We're going to talk about, go ahead.
Yeah, there's one more question.
Okay.
So Cindy says they collect a lot of data, and it seems like a hard process for management staff to use the PDSA with the data or use of other tools. Any suggestions to get them comfortable with how to use the data from the PDSA or other tools?
Yeah, we're going to do an example in a minute that includes doing PDSA cycles. Typically what happens with organizations, I see it time and time again, staff conceptually understand what a Plan, Do, Study, Act cycle is. They conceptually understand what population health management is. But when it comes to actually pulling it off in real time in a clinic that's crazy busy, and you have staff turnover, and you have leadership that's distracted by all the things going on in healthcare today, it's really hard to execute on it. So we recommend that you put together a very simple work plan, and that work plan articulates some very reasonable goals based on where your organization is in doing this work, and you get some early wins. And it might even seem too simplified, but I don't think it can be too simplified when it comes to starting out doing this work. And get some early wins so staff start to build up their capacity to do this work, and then you can move to the more complex, higher level PDSA, population health management type work. But I'd love to talk with you more about exactly where your organization is, because we see this all the time. Organizations, they either overshoot their work plan by making it way too complex, and then people just get discouraged and don't know what to do, or they make it so simple people just don't think it's, it's the real deal, and they don't do anything either. There's this like institutional inertia that sets in. So can't say much more than that. I think what I'm going to talk about next might help a little bit to kind of elucidate how to do some of that. Other questions? Those are good questions. All right, well, let's dive into it. So let's do this first step. Know what to ask about your populations. Pretty simple. Really, you just have to know in today's environment, what is your payer paying for? What is the state of Montana Medicaid office wanting from you as a provider? Or you can get creative and say, maybe we don't feel like we're serving a certain ethnicity or sexual orientation, group of people in our community. We want to serve those folks better or more of them. So we're going to design our population health management initiative, our quality improvement initiative around doing that. There's a whole myriad of things you can look at, but the most important thing to look at is the thing that has urgency within your organization. Urgency defined as payers are demanding it, or it's keeping your senior leadership up at night. Focus on those things. Focus on the things that are killing people. What are most people in your organization that you serve dying from? Is it high blood pressure? Is it diabetes? Is it obesity? Or what's killing your organization from the standpoint of cost or staff burnout? Is it high ER use? Is it high rate of people going to jail? Pick any one of these things. You can kind of design your population health management project around it. That was simple. Second step is to get that data registry in place. So let's talk a little bit about what a patient or data registry is. Very simply, it's a system where you put uniform data into one place, one data set, and you can risk stratify, you can cut that data and look at it from any disease condition or any position that a patient that you're serving is standing in. So you can look at it from the standpoint of whether they're homeless or not. You can look at it from the standpoint of whether they come to their appointments or not, or follow through on their treatment plans or not, or how much they cost. It allows you to take all this data you dump into your EMR or put into your record and organize it in a way that it's going to tell a story that you want to hear the end of. We want to know how well we treat people with bipolar disorder. We want to hear what that story is. So you pull the data and you look. Easier said than done, for sure, but the simplest version, as I mentioned before, is an Excel database. And Excel databases can be aggregated into Access databases where you can look at lots of different data points. Sometimes managed care companies will have portals that you can mine where you can go and pull data. Certainly your electronic medical record or your electronic health record, whatever term you want to use, has registry functionality within it. Health information exchanges technically are not registries. They don't have that capacity because data just flows through them. They're kind of like a pipe at a junction where information kind of flows from one spot to another. It never stays there for you to mine it. So Excel spreadsheets, managed care portals, your electronic health record, or as I mentioned before, if you've got the money, you can buy third-party, off-the-shelf population health registries that will allow you to dump your electronic health record into it and cut the data in different ways. each data registry has to have a way of giving the data its specifications. So not surprisingly, you're not going to just randomly dump a bunch of blood pressure scores into a spreadsheet and think that that's going to tell you the story. You have to enter the data into the registry in a way that everybody understands it. So the best way to do that is to have measure specification protocols for your data. So basically, for any data point, whether it be a blood pressure or the PHQ-9 or anything you put in your record, really, you need to have a measure description explaining what is this data point. And if you're going to use that data point to analyze treatment processes or outcomes, you need to define, and I'll give an example in just a moment, define the numerator and the denominator. The numerator and the denominator defines who's in this measure and who isn't. So if I'm going to do a quality improvement project, a population health management project, that includes looking at African-American males who have high blood pressure, which we know is a real issue because they have higher blood pressure than any other population, in our denominator, that would be the number of African-American males we treat. And the numerator would be the number of African-American males who have high blood pressure. That would give you how many African-American males with high blood pressure you have in your data registry. We would exclude African-American women. We would exclude white males because they aren't part of your denominator. Your denominator is the population you're going to pull from. So having that formula is really important so that everyone understands what data you're looking at and how you're using it. Having exclusions in there is very important so you know who's in your denominator, who isn't. And then having reporting periods is important because sometimes, if you want to impact body mass index, that's going to take probably a couple years to impact that for a population that have a BMI of over 30, the overweight group. So your reporting periods are going to be over years, right? You're going to watch it quarterly for a long time before you expect those to change. Whereas if you're working with high blood pressure, you would expect someone's high blood pressure to come within normal limits soon after getting on a medication for their high blood pressure. So you could look at it over the period of several months, to see an impact. So the reporting periods are very important. And then measure-specific diagnosis and billing codes. So you're coding things accurately in your electronic health record, and you're linking those codes to cost. This is that value-based purchasing aspect. You will be seeing in the future your payers coming to you saying, if you are able to see someone within 7 days of discharge from an inpatient facility, if you can see them for an intake within 7 days, we will give you 100% of the money we used to give you. If you can't, then we're only going to give you 80% or 70 or 50% of the money we used to give you. So it's important that staff and your electronic databases have billing codes assigned to these different diagnostic codes or service codes. And this is why we talk a lot about the importance of having structured data fields in your EMRs, getting away from narrative. It's important that you have a code, whether it's an actual billable code or just a code that's going to tell you what the staff did, like they did care coordination or they had a team meeting where they discussed a particular client. There is a CPT code or a HCPCS code for just about everything you do during your day. Put that code in your electronic record so you can get credit for it and link it to these different population groups you're working to improve their health. So a simple example, this comes from HEDIS, ambulatory care sensitive condition admission. Simply means that anybody admitted into services that should have been able to be treated in the community. So this is the person with diabetes who goes to the ER. That condition is a sensitive condition, but it should have been able to be taken care of ambulatorially or in the community. So this is a HEDIS measure, and it clearly describes what it is here, gives you your numerator, gives you your denominator, your exclusions, your formula, and your reporting period. And this is kind of an old example because we got ICD-9, we're up to ICD-10, but it kind of gives you the codes, well, not kind of, it does give you the codes that describe who's to be included in this population health management data capture and who's to be excluded. And ideally, you would also have some cost codes associated with those. So once we've got our question we're going to ask of our population, we've got our data correctly assigned in a data set that we can mine it and do risk stratification. We want to look at our quality improvement processes to make sure that we can do the work of rapid cycle change. So rapid cycle change, as many of you know, is this plan, do, study, act process where we define what do we want to do. This is the plan, and this has everything to do with defining what population health management project we want to take on, what group do we want to work with. So we put a plan together, and we say we're going to restructure our processes to impact these numbers. We've defined high blood pressure as something we want to improve. We're going to implement a care pathway for high blood pressure. So we plan it all out, and then we actually put that care pathway into motion, and we test it. And that's the do part. So we test it out to see if staff like it, if patients like it, if it actually works, and then we study it to see when we pull our data on our care process, did it actually work or not? If it worked, we put it into production. It becomes our policy and procedure. It's what we do now every day. If it doesn't, we go back to plan, right? Plan, do, study, or check, which is that testing the data to see if it worked, and then act. Remember, act is that final step. You have data, information, knowledge, and then you act. You act in the direction of producing a policy and procedure if your intervention worked. You act in the direction of going back to your drawing board if it didn't work. Go back to the plan, do, study, check, act cycle again if your intervention didn't work. And you just keep doing that until you get the desired outcome you're shooting for. It's really important that when you're doing your quality improvement activity, let's use high blood pressure again. It's important that staff know where they stand, what your baseline is, and where you're going. Where do we want to be? So maybe we don't have a way of capturing blood pressure because we're a behavioral health organization. We've never done it before. So we want to implement a procedure for collecting blood pressure and getting our baseline. Baseline being how many people we serve have high blood pressure. Something as simple as that, it sounds very simple, but that's a huge undertaking. You got to put a plan together, then you have to execute on that protocol, that plan you put together, study it, see if it worked. The best way to help staff through that process is to have really good dashboards. Dashboards tell the story of data. It allows the data to speak. It allows the light of data to shine through. And many of us already use dashboards all day long. It's on our phones. It's in our cars. But we need to have it in our clinics, in our supervision meetings with staff, in our team meetings, in our executive team meetings. And this is a really simple thing that many of us just don't do. Having the data in front of us allows us to monitor, analyze, and manage our work. If we don't know what's going on with the data, then we're flying blind. It'd be just like driving down the road and just putting duct tape over your dashboard, not knowing how fast you're going, if you have gas left. Many of us do this all day long at work. We have workflows that we engage in, repeated behaviors, and we have no knowledge of if they work or not. We have no data to show if it worked or not. So having dashboards is really important. You can have dashboards with cost, with operational components, just about every aspect of our work you could put into a dashboard. It's important, however, to put it together a dashboard that's specific to your particular population health management or your quality improvement project and slowly build more complex dashboards. If your organization doesn't have dashboards, don't start with a dashboard with 30 items on it. Start with a dashboard with 2 or 5 items, or maybe 3. Use it for a little while and then slowly add new data to it. And it allows people to habituate to the data. So if you're doing a quality improvement project around high blood pressure, do that for 6 months. Look at those data. See if your protocol works. Get it working. Put it into policy and procedure, and then attack diabetes. Now start adding diabetes to the dashboard with the high blood pressure. And at a very fast period of time, within a year or so, you can have a lot of data on a dashboard that staff are easily able to read and understand quickly. So once you've chosen your population health management focus, you've got your data together and you're able to describe it, risk stratify it, and you're putting your quality improvement process into place and testing out that intervention, and it works, then you need to keep it within specification. So this is that whole process of continuing to watch the dashboards to make sure that the data are falling where you want them to. And if they don't, doing rapid cycle Plan, Do, Study, Act processes to get it back within the specifications you want it, or in control, as they say. Supervisors are critical in this process. As you get new staff coming on board, as you get staff stressed out by all the things that stress staff out today in healthcare, supervisors have to keep the focus on the data to keep it where you want it. After you finish your quality improvement activity, you've got to maintain that improvement. And supervisors are critical in coaching and managing staff to be able to do that. So let's do a quick example, and then we'll have some questions for you all. Let's look at depression. This is a good one. So know what to ask about your population. Our organization said, you know, we want to know how well we're doing in treating people who are depressed. Pretty simple. That's our project. We are going to look at how well we treat people who are depressed. We're going to pull our data together. Luckily, we have PHQ-9 scores by team and clinician because we got a pretty good electronic health record that has the registry component. So we pull these data together and we look at them and stratify them by risk. And we use a dashboard like this to do it. This is a free dashboard from the AIMS Center, University of Washington AIMS Center. And you can see it's got the risk stratification built right into it on the right-hand side there. It shows you who's at risk and what to do. It's got green checkboxes for people that are doing pretty well. It's got exclamation points for people that need attention. And it clearly articulates on the dashboard what to do with the data, what the data means. It even includes GAD-7 scores, which is a screening tool for anxiety. I figured I'd just throw that in there too to show how these dashboards can get bigger and bigger pretty quickly once we figure out how to treat a specific condition. You can start adding new care processes and new conditions to them. This is another example of some dashboards that an organization put in place that really calls out the risk category change. So they were really interested in who are the people that are doing well, who are the people that are doing poorly, but who are the people that are almost at the point of doing poorly. We want to get to them before they become, you know, the group that's in the ER or the group that's frankly dying of their health conditions. So they really did a nice job of defining their populations and looking at them from the standpoint of people who are doing well, people who are at risk, and people who are doing really poorly you need to act on quickly. So once you've got those two pieces done, you know what you're going to ask of your population. We're looking at depression. You look at your data. Then you develop a quality improvement project to get those data where you want them to be. You're not happy with your data. You want to change the data. This would entail deploying a quality improvement process and some tools, likely the Plan, Do, Study, Check, Act, but you might, in the Plan, Do, Study, Check, Act, use a fishbone diagram. You might do a whole variety of different quality improvement tools to get at what you want to fix. You might have to do a workflow analysis. Many of you that are working with us in Montana have done a swim lane workflow analysis, because you really want to look at the whole process of bringing someone into treatment, giving them the PHQ-9, and then monitoring those scores over time. So this group said, we really just need to assess our workflows because our PHQ-9 scores are all over the place. We want to standardize our workflows so we're certain that our PHQ-9 scores are being collected reliably. So you put your process together, you test it out, you plan, you do it, you test it, you study it or check it to see did it work. And if it works, then you go ahead and put it into practice. So here's an example of a workflow that a clinic did in New York, where this is their workflow for depression screening. The workflow includes all of the data collection, related to cost and clinical scores and position. So it really lays out who does what. They also had a disease pathway. The disease pathway fits right into the workflow. The disease pathway is actually the clinical pathway or the disease pathway that the patient goes through if they have depression. So everything from screening and identifying they have the condition, then what to do to manage the condition with the patient based on their signs and symptoms. So it clearly lays out, this is how we treat depression. This is our brand, this is who we are as an agency, and this is how we treat depression in an evidence-based way. So this depression protocol is evidence-based based on the impact model out of the University of Washington, and clearly lays out how to use a PHQ-9 score and move someone from a point of being identified as depressed to someone who's no longer depressed because they're responding positively to treatment. So having a workflow that defines the administrative, the data piece, where you enter the data, how much it costs, how much the time it takes to do this actual care pathway for depression. So this is the efficiency piece. And then this slide really shows the effectiveness piece. Are we able to do it in an evidence-based way and produce the outcomes we're shooting for? Are we hitting our treat to target metrics? So once you get those into place, you have to monitor it. This is the final step where you're just doing continuous quality improvement. You're looking at your dashboards to make sure that the people who are depressed are getting better, who are identified as being depressed are getting better. And you incorporate this right into your policy and procedure. So supervision, huddles, administrative meetings, everybody understands how to treat depression now. You have a standardized way of doing it for your population of depressed people, and you watch it. You watch that process using continuous quality improvement methods to make sure that everybody's doing it the same way. This is why supervisors are so important, because you don't want a couple clinicians doing it differently, radically differently, because you're going to get different results. You have to standardize your practices to make sure that people are moving towards the treatment target you've established using the evidence-based practice you've defined flows in your disease pathways. So this is just an example, again, from the same Institute for Family Health. This is a dashboard they use to monitor over time depression scores. They're pretty good at it, so they just use this to monitor quarterly how they're doing as an organization with depression. And you can see up there they have their definition of what improvement is. And this is an evidence-based depression improvement definition that comes out, again, of the AIM Center. So everybody's clear on whether they're doing a good job with depression or not. Now, I've made this sound pretty simple, and I'm someone like you that's worked in the field a long time and tried to do these things, and they've been really hard, frankly, to do. This is not easy to do. I might have made it sound easy, but it's not. And if you look at the research around what good organizations are able to do, organizations that are good at doing population health management or using data to inform care, they all have these components. They have accessible, high-quality data. So you might have just some data that's high quality. Start with that. You might have a paper record and have to use an Excel spreadsheet to aggregate your data. That's fine. Just pick a population health management project that's going to be meaningful to you guys. It's killing people or costing you a lot of money or both. Get high-quality data. You need really structured data that's high quality. And then these organizations that do this well have an enterprise orientation. Their senior management have a strategic plan that really clarify how they're going to exist in the healthcare marketplace today. We can no longer see ourselves as social service type providers that are just doing community good. We are now in a competitive healthcare environment. It's just a fact of life. So having an entrepreneurial enterprise orientation is really important. Knowing what your targets are as a strategic plan and going after them and getting them. The leadership have to be analytical. They have to be looking at data on a regular basis and analyzing their performance as leaders in achieving the strategic plan, and analyzing the department's performance, analyzing the team's performance, and analyzing the individual staff's performance in helping people improve their health. And for that, you need to have clear numbers stating, this is where we are today, this is where we're going to be in 6 months, in a year, in 2 years out. And then finally, you need analytic talent. Sometimes you can, promote a social worker into a quality improvement role or utilization review role, and that works. But a lot of times it doesn't. You have to go out and hire somebody who has specific skills around quality improvement, data aggregation and analysis, people that have backgrounds in statistics. So good organizations go and try to hire that talent or train their current talent to be able to pull that off. These are the competencies that really good organizations that do this well have. And there's a nice little acronym to remember it. It's the DELTA here from Davenport, Harrison, Morrison. So having said all that and having 10 minutes or so left, any questions or comments?
Please feel free to raise your hand so I could unmute you just in case you would like to say it rather than type it, or if you would like to type it, just fill it in on the right-hand side in the chat function.
Come on, we got to do Joan proud and have at least a couple questions. She said, you're not going to be able to get through this with enough time for questions. And I said, yes, I will. I talk really fast. So I'm sure there's somebody out there that's scratching their head about some aspect of this. I think you're all going to see more and more of this coming to the state of Montana through the feds, down through the Medicaid office to you all. This whole notion of value-based purchasing, population health management, and stratifying your populations by risk. And really designing high-quality care pathways, disease pathways, whatever you want to call them, to deliver very specific treat-to-target care to people. And luckily in healthcare today, you guys are in a better position, I believe, than many of your peers in primary care or specialty care or hospital services, because you do something that they don't do very well, which is patient activation. You can actually educate someone pretty well and monitor their treatment plan pretty well. It might not feel like it, but you do, to the point of them being able to achieve their target or not, which is a huge advantage you have over most of the field. So learning the data piece is easy compared to activating patients and engaging patients in a way that leads to them choosing to change their health behavior towards one of health. So I bought you all some time by talking there. Any questions come in?
We have one hand raised. So I'm going to unmute Cynthia's line.
Thank you.
This is Cynthia, and yeah.
Hi, Cynthia.
Yes. Hello. Yeah. How's everybody?
Great.
Hey, thank you so much for going through the process. One of the things that I'm in Dillon, Montana, and we've been working for about 2 years now on several projects, and we are actively in an integration model for behavioral health within primary care. So knowing how to start, because there is so much, and how to kind of bring a team together to concentrate on one focus has really been kind of a challenge, because we feel like we need to make sure our LCSW, Jenny, and our primary care providers first come to kind of a recognition and agreement on, for behavioral health, what are some key measurements where we want to start, because it's all new to us. So one of the things is using the PHQ-9 and how to roll that out in a way that, let's see, respects the fact that patients are sensitized to having that evaluation, and that providers are sensitized to making sure that when we act on the results, we, one, have enough access So we're kind of closing the loop and not just identifying a problem with nowhere for it to go. And then I think, yeah, and I think for Jenny, it's just a part of the work that she does. So we're confident that once the referral happens, Jenny is using those tools very effectively. So our first step has been really to just get everybody to come to some agreement on how we roll this out to the general patient population to first identify the issue. The second is the referral piece. So we've decided to just really start in keeping it real simple, measuring the use. How many times do we actually complete the PHQ-9? And that's kind of our first step for this next 2 quarters of time. And then I'm hoping we have enough data to then begin to kind of track and say, okay, now what does the data mean? How does it then, in your words, become information and actionable? And get that back to the general primary care group along with Jenny. I think the challenge is not going too far down the line too fast. And I guess I'd like to know how you can advise us. Are we starting too simple, or does it make sense that we bring everybody along to make sure that we're actually able then at 6 months of time really become more actionable about what we're seeing in the trends?
No, I'm a big proponent of simple. Usually organizations develop a work plan that's just so big, it just, any spark of interest they have, they just blow it out with this crazy work plan that overshoots everything. So having something simple is great, because in the end, as you're probably experiencing, even though it seems simple, it never is, because there's just so much work to do in the workplace, and there's so many things that get in the way. There's so much institutional inertia in an organization that gets in the way of doing quality improvement. It's really important, though, that you have a target, and ideally that the senior leadership is creating urgency within the organization to hit that target. If you don't have senior leadership really driving the process, it makes it harder when you run into people who are confused or resistant and just don't want to deal with more screening and more people. What's the deal with PHQ now? We do it fine already. If you don't have that senior leadership really driving that urgency, you can run into those barriers. So doing things simply and based on what the team sees as being a useful target for their quality improvement effort is really important. So have you guys defined that, getting good, reliable PHQ-9 scores and really getting your process down for how you give the PHQ-9 and collect the data in a really reliable way is the first thing you're working on? Is that what?
Yeah, it is. It is, because I think we frankly had to have some very open conversation about how providers saw the use of PHQ-9. And once we had those conversations, what we recognized was the concern was not about using the tool. The concern was about recognizing a need that then we couldn't fill. So now we have one full-time LCSW, Jenny. We've just hired, and we'll have the second the end of October. And we're feeling for the support of 10 primary care providers in a population of about active patients with us, at least starting there to kind of refine the process, because we know they're in the system. So at the end of 6 months, we're hoping to then set a target, because we didn't feel like we knew enough, and we wanted to make sure the target.
Yeah, you have a target now. So the target right now is reliable PHQ-9
Correct.
scores, and once that target's hit, then you can move on to the next one and celebrate that.
Got it. Yes, we have a process target, not a number or completion target. Yep.
Awesome.
Okay, I was just verifying, because sometimes it feels like to get your arms around all of it within primary care practice. You're right, it becomes tough, but it becomes very real when you know that the work we're doing isn't working. And we've had that experience over the last 3 years about feeling like we didn't support well patients that we care about. So at least we're now starting toward that end.
keeping the fire going, being, you know, rah, creating urgency, not letting your eyes off the ball is just so important in these quality improvement projects. You almost have to make it a little silly and funny for people to remember, oh yeah, we're still doing this. Because people just get distracted. It's just the way we are as humans. Great question, thank you. And I think we got to move on to upcoming activities, right?
Yes. So we have two group coaching calls coming up. This is October 12th and November 10th. The call information is on your screen. So it's 888-727-2247, and the call-in ID is 347-8556. There's one more question that I'll follow up with Jeff from Jocelyn, and I want to be respectful of everyone's time, so because it is 4 o'clock, I think we're already, we want to thank everyone for being on this webinar. And Jeff, if you don't have anything else, we can conclude this webinar.
I just really appreciate you guys taking the time with us today, and please be in touch if you have any more questions. Have a great day. Thank you, everyone. This ends the webinar.
Thank you.